Hi, everyone. We are back. This is an extraordinary broadcast, and we've got an expert with us who is renowned nationally, Andy Pow, who has been and is a expert on medical accountancy and medical finances. Andy, introduce yourself.
Yeah, well, thank you very much for that introduction. I don't think I've been reached dizzy heights like that before. So I'm a medical specialist accountant. I have been for over 30 years, and I'm also married to probably an ex-GP now, because she has now retired.
Yep.
But I've been advising GP practices, federations, PCNs, everything to do with that GP space for a while. I used to be in a sort of big national firm, accountancy firm. I'm now just a small consultancy firm, but we do lots of different projects, really, which is quite interesting.
What's the name of the consultancy?
The name is we spent ages over this, so it's myself and Melanie Thomas, so it's called the Pow-thomas Partnership. So yeah, not much time was taken in terms of naming ourselves, but so we're out there just advising and helping a few GP practices with some hands-on stuff and some really interesting project stuff at the moment. But I also continue to be involved with an organisation called ASMA, who are the Association of Independent Specialist Medical Accountants, which is a network of accountants across the country that look after GPs, and it's kind of through that I've really developed my interest in GP finance.
Brilliant. Yeah, and we can attest to the fact that Andy and his colleagues have helped us over the past, well, certainly me for the past 25 years, and the partnership here for a lot longer. So we're dealing with people who know their marbles here, and I wish that the policymakers would listen to them as well, because they really know what they're doing. Andy, today we're here to discuss the funding formula review. The government's said that it's going to take 6 months to review the Carr Hill formula. So I thought we'd do something on that to make sure that everyone knows about this, because there's lots of ignorance out there about what Carr Hill is and how GPs are funded. So we just want to go through that at breakneck speed, but we just want to give people an overview, and also the people that matter, the policymakers, an introduction to how complicated this is, how easy it could be, and how you could actually sort out a lot of the problems of the NHS by getting this right.
Or how many mistakes you could make, serious mistakes, by getting it wrong.
And we'll go into that, because they did get it wrong, didn't they? Yeah. We're talking too much, Andy, over to you. So if you could just tell us where we are in this space in terms of the Carr Hill formula.
Yeah, so just to sort of stepping back, a GP practice in the main is effectively it's independently contracting to the NHS. So you're not employees of the NHS. You get a contract and you get paid through that contract, and you get a number of income streams. But by far the biggest one is the global sum. And the global sum is linked to your capitation. The global sum is probably, I don't know, about 75% of overall funding. You also get funding from other things like the Quality and Outcomes Framework, but that's been reducing. So that's a target-based system. So for doing
capitation, what do you mean by that? What do you mean by capitation?
So capitation is really just the number of people registered on your list. That's the starting point. But it's a lot more complicated than that, because actually it's not just the number of people you've got registered with you. But yeah, on top of that, you get other bits of income, but actually it's the core driver by far. And the complication behind this is that because you're an independent business, you have to get income in from basically one customer, and you have to then run all the costs of running a business. And it's the same as, Costa Coffee, it's the same as Tesco's, it's the same as, the BBC. You basically got a whole lot of premises costs you've got to pay for. You've got all your staff that you employ you've got to pay for. You've got to pay for your stationery, your telephone costs, the long list, and all those IT glasses that you keep buying from time to time have to be funded. Out of which then it leaves effectively a profit, and the profit is the bit that pays the people that run the business, which usually is the GPs or maybe sort of non-GP partners. So actually, it's kind of a quasi business in that you get all this money in, all money out, but actually what's left is really funding people's time as well.
Yeah. And you compared us to a few retail organizations there, but there's no price signal in general practice, is there?
No, I mean, the difference is you've got one customer and the customer sets the price. In theory, in negotiation with your representatives, but I think over the last few years, that's really not really applied. But yeah, no, the customer sets the price, and the customer, to be fair, is limited by, lots of restrictions. It can't just create extra work for itself. It's the government. The government have to collect money through taxation. So it is a kind of strange structure, really. But it has worked well, because I guess the difference between GPs and hospitals, for example, is you're given a fixed budget. Okay. You've got to spend that fixed budget. If you don't spend it wisely, you don't get paid. If you're in a hospital, if the chief exec of the hospital doesn't spend his budget wisely, he gets a rap on the knuckles, or she gets a rap on the knuckles. And, they may get some, visits by consultants telling them to do things better, but it doesn't affect their pay. But fundamentally, in general practice, it affects people's pay. So ultimately, it's quite a good deal for the government in that it's the one part of the NHS where they actually know what they're spending, and they know they're not going to spend any more, because you have to work within the budget you're given.
Absolutely. So we never run a deficit. We lose our houses, literally, if we don't get this right. So every single penny that we spend is spent wisely. And unlike in a hospital whereby, I'm not going to criticize my secondary care organizations too much, but it's a totally different ethos, isn't it? They're spending someone else's money, whereas we're spending our own money, and we're spending every penny absolutely wisely.
And, the other bit I think that's really important is we're here. We're stuck in this population. I can't make bad decisions and move on to another job. I have to stay here and face the consequences. My patients keep knocking on my door. Whereas, like in secondary care, you can, move to different jobs.
We're not going to go secondary care, Bush.
No, we're not.
No. Okay. So we're at the stage now. So where does the Carr Hill formula fit into this, and why is the government announcing this funding review, the Carr Hill review?
Yeah. So if we go back to the say 75% of the overall income is paid through an income stream called the global sum.
Yeah.
And that's linked to the registered population that you've got, so patients registered with you. But this all came back early 2000s, really, when the formula was changed. Prior to that, we used to have a system where GPs got paid by a convoluted long list of services and allowances and all kinds of things. Red Book, under the Red Book, for those that remember.
I remember as well.
So it got replaced, and as part of that, the idea behind it was actually simplification. Actually, we're going to get rid of all these income streams and actually replace it by just one or two. The core bit being the global sum, but quite rightly, they sort of said, well, you may have 10,000 patients on your list at Wilmslow, and there may be 10,000 patients on a list in the centre of Manchester. And that population is different. So we need to factor in some kind of formula which tries to reflect the differential workloads that practices have. But it never really worked. But we're stuck with this formula, and we've been stuck with this formula for 21 years now. And we're now at a point where actually they're acknowledging it doesn't work and we need to revisit it. But I mean, I don't know how much you want me to go into the formula, but there are probably 6 different real areas. The first one is age sex differentials. So if you take someone like myself, you can compare it with my dad. I don't go and see my GP that often. Perhaps I should do, but touch wood, I haven't needed to so far. But my dad, who's now 84, goes quite frequently. So his demand on the system is a lot bigger than mine. So his weighting that gets applied to him, being an 84-year-old, is probably 3 or 4 times what my weighting is. So it's around that. So you've got age, sex, you've got a factor for things like, patients that are in nursing and residential homes have a bigger demand. So there's a factor based in there. There's a factor for list turnover, which is really designed around perhaps, big populations which are always on the move. A good example is student populations who come and go through universities, because the practice is required to register them, deregister them. There's a cost to actually just getting them on the list. The other big factor is then rurality as well. So rural practices, because of their inefficiencies that come with the cost side, got a rurality adjustment. So I live in a rural area, and my wife's previous practice area, the geographical size, it was 1/4 the size of London. A lot of sheep, not very many human beings. But to actually just do a visit there, it could take 2 hours to go, there and back. So it was to factor in things like that. So we have all these factors that get applied. And ultimately, across the country, once you do all this maths, effectively you got 63 million population, and we got 63 million payments going out for patients, and they actually equalize. So all this is doing is trying to weight things around different factors.
And
now, the one factor.
Go on. Sorry,
the one factor I haven't met is the final one, which is the real crucial one to where this review's going, which is something called additional needs.
Right.
And additional needs was basically it was pretty weird. It was at the time, and you have to remember all these factors around a lot of them around additional needs were set back in the late 1990s, and they haven't been revisited. And this is where the problem is. Life's changed, populations have changed, but that calculation was actually looking at mortality figures. And it was looking at life-limiting illnesses, but they were really the only two areas really affecting additional needs. Whereas we know full well additional needs is far, far more than that. So it was an area that never really worked, and those particularly deprived areas, have always said that actually it's never worked for them, which is where we are now in terms of a review.
And it never worked from day one, because there was a history there, wasn't there, about when it was implemented?
Yeah, absolutely. And this is, I think, as Barry said right at the beginning, getting it right is going to be crucial for this next phase, because they didn't get it right in 2004. Basically, we got to a situation where they, did all these calculations and worked out what price per patient people were going to get, and then let practices know what they were going to get, and everyone compared it with their existing income. And a very large percentage, I can't remember how much it was, but I think it was at least 75-80% of practices actually ended up in a position where they were going to get worse funding. And back then, general practice was in crisis. People weren't being recruited. Perhaps arguably worse than it was now. So it was a real problem. And they effectively had to bring something in called the minimum practice income guarantee to fudge it, to make sure practices didn't lose out.
And that was phased out over the years as well, wasn't it?
Yeah, so that case stayed around for quite a few years. And then the problem with this, and this is the classic problem with the NHS, is that it has a lot of organisational knowledge which gets lost from when we have changes in structures, changes in personnel, changes in who's in government at the time. So they lose.
That's why we need people like you. That's why we need
people that have been around long enough.
People with excellent memories.
It's a really important issue, isn't it? Because people move on. The policymakers, the young spuds move on, and actually, no one actually remembers how we got here. And the history is actually really, really important.
Are you saying that we just recycle the same ideas?
Well, I'm back. I wouldn't dream of saying that. So we're at this situation now where we're looking at Carr Hill, and you've talked about the risks of using these blunt markers to make a new kind of funding arrangement. The dangers are still there, aren't they?
Yeah, absolutely. Because all we're going to do is end up with a position where we have the same funding, just being distributed in a different way. What you're going to have is some areas gain, and there will be areas that do need to gain. This is acknowledging the fact that actually some areas have, been underfunded for what they need to do. But to a certain extent, that's going to get raided off other areas. And the real worry to me is if you have that kind of situation, actually some of those areas which are doing okay at the moment, and I really get annoyed when ministers come out and say, the NHS is broken. It is not working very well in some places. I acknowledge that. But actually in other places, it's working very well. I had a really good experience last week, personally, of the NHS working in my family, and it was brilliant. And my worry is that those areas where it is still working well, start with the ones that end up losing, and it could put them into a position where they can't provide a good service anymore. And then we're ending up probably with a worse service across the board if they get this wrong.
So they're saying that they're going to look at deprivation. They're really on this mission now for health inequalities, and they're saying that they're going to, build deprivation into the equation. And it might have featured in that additional needs thing, but I think it's going to feature even more now.
I think, to be fair, there is a general acknowledgement now that the formula is not fit for purpose, and also at government levels. That actually Carr Hill itself might now be, pretty close to the scrap heap.
Yeah.
The issue is, whenever I've raised this before, and certainly when we had the minimum practice income guarantee being taken out, particularly in rural areas, it was a massive problem, particularly for small rural practices. And I had meetings with NHS England at the time in some very peculiar locations, up here where I live in the Lake District, and they acknowledged at the time it wasn't working, but it was too difficult to change, because the dynamic, if you change one thing, it affects someone else.
Yeah.
So we're in a position now where I think the government have installed, the Department of Health instructed a review, which is going to be very much an academic-led review into what could be proposed as a way forward. And within that, what it's trying to deal with, looking at things like frequent attenders, which might not just be deprived areas. You could have a very young person at the moment which gets a really low weighting, but you see them time and time again because they've got mental health issues going on and things like that. So it's trying to look at that. It's trying to look at, obviously, the people with multiple issues going on, which are very complicated. But it's also going to acknowledge that actually there are some areas which the social economic factors have an impact in terms of health, and therefore an impact in terms of demand. So it's going to be looking at that, but they're also concerned that actually perhaps some of the data isn't actually out there, because if you've got let's say a coastal GP practice which has been struggling for years on years, doesn't have the right number of staff at the moment. People are trying to phone up for an appointment or book an appointment online, as we know now, but can't get an appointment. They don't go and see their GP. They just, may go and attend A&E. Actually, those people are being missed out the system in terms of actually tracking that data. Whereas if they were in a great practice where they got great access, actually they'd be recorded what they're being seen for. So it's trying to deal with that as well. So there's lots of things it's going to try and deal with, out of which someone's got to produce a model that might work, which is going to be interesting.
So do you think, though, that people are getting confused between need and demand, and that maybe some funding needs to be sent across to the public health organizations rather than, taking funding away from more affluent areas, for instance? Because people do come and they visit us regularly. And the demand in these parts, people think it's quite low, but it's actually not. And people are living till their 80s and 90s, and they do visit a lot, and they have a lot more need than some others. I'm not trying to compare ourselves to kind of less affluent areas, but that's the big worry for suburbs like this.
Demand is it's high across the board, and that's the problem. So if we don't have a net investment going in, it's not going to solve that problem. In fact, you being in a very nice area of the country might be one of the losers potentially, and you're just not going to be able to provide that. So you're going to have to deal with that, because it goes back to you've got to break even, including paying yourselves. You can't run at a loss. So it's going to be down to what you offer your patients. My worry with all of this is it's focused on, it'd be focused on academic data. And I'm not doing a disservice to academics. Extremely good. We do need academic data going in, but actually these are fundamentally businesses that have to be run. So if we don't actually build into this review a couple of things in terms of acknowledging cost differentials that exist. So I can imagine, again, in the area where you are, property prices are a lot higher. Actually attracting staff will be more difficult, because you've got to, they've got to keep have good wages for people, because they can't afford to live locally otherwise. You might be in premises which are have costs that aren't reimbursed, which are far higher than other premises. There'll be differences there. Lots of different differences. You know, you want to invest in your IT side and your, actually invest in developing the practice and developing new ways of working quite well, but you need funding to deal with that. So there's always going to be those differences. Unless you factor those differences in, any formula is not going to deal with that, which is the problem. Secondly, my concern would also be that we risk shifting funding to parts of the country that can't really use it.
Yes.
Now, it's not necessarily a strong argument, that one, but because they do need the money. But unless actually you've got proof that how it's going to be used once it gets there, just shifting it really doesn't solve the problem. You know, if you cannot recruit a GP to the west coast of Cumbria because no one wants to go there, it's going to be really difficult to actually spend it. So I think somehow they're going to have to factor in actually what's the effect on the business side of here. If they don't do that and don't appraise that, they're going to get it spectacularly wrong, I'd imagine.
Yeah. Sorry.
No, I was going to say, and some of this seems to be running counter to some of the things we're hearing about GP seeing 90% of urgent all the day cases. How is I'm just thinking, if our funding goes down, we provide great access, she says in a completely non-biased way. But I already know it's skewed what we do. Worrying times, I think.
Yeah, I mean, and there's really good examples of, particularly practices that had a really low Carr Hill in areas that needed high Carr Hill. And I gave a good example on X the other week because I'm a bit nerdy. I've studied this for ages, and particularly, declaration of interest. My wife was a GP in a very low Carr Hill rural practice, and rural practices tend to have higher weightings because of being rural. But if you looked in her PCN, and this is what, just highlights how bizarre and difficult, got one PCN, I think it had 8 practices in, and they got paid for 97% of their patients. And the highest practice got paid 121% for their patients in the same PCN. And we see this across the board. You get massive differences. So it's it was basically, one practice effectively got 23, 24% funding, higher than another, but you've still got the same costs of dealing with that. And actually, it was interesting. I've been arguing the case locally for years on it, a bit like a stuck record. But I went back and revisited that because my wife's practice handed back their contract in the end because actually they just couldn't make the numbers work. It was really peculiar circumstances in a rural area. It couldn't make the numbers work. And when you look at that list, everyone at the bottom has handed back their contract. So so there's in that PCN there's 3 practices that have handed back their contract, which in theory looks like a beautiful leafy area from the outside, that everyone talks about, wealthy, etc. But there's a hidden underlying issue going on here that they have to deal with. So the issue there is that then, ultimately it gets transferred to another provider. Often these practices don't disappear, but actually the list gets transferred to another provider. And I'm not going to sort of do disservice to those people, but
they cost twice as much, though, don't they?
Well, they've got different different cost structures to them. A big corporate entity will have a different cost structure, and you've got different types of corporate entities that do it, but they've also equally got to make a profit out of it. So they've still got the same issue. They've got a smaller funding. Actually, reality, what happens is eventually, usually, a lot of these contracts, I'm not talking about my local area here before people complain to me, but in other parts of the country, when they actually issued the new contracts, they gave them more funding. Because fundamentally, no one's going to take it on unless they can make the numbers work. So you end up with a situation, basically, where you don't have that, necessarily that local driven healthcare service anymore. And that does have a hidden cost, which eventually does, come out somewhere else in the system. So if we don't get it right in GP level, it will have a cost somewhere else.
Yeah, absolutely.
And the other thing is, don't forget, is the smaller practices where they know their patients. They're the ones who score really well in what's it called?
The
patient survey. So if you look at the people who are top of that list, it's not the big collections, it's like the smaller practices. So in a way, the fear is we'll actually penalize the people who are doing this really well.
And by knowing your patient, actually, I think you're more or less likely to refer them to hospital, because you actually be able to deal with you can get to the bottom of what's going on. General practice is an art, not a science. I always say this, and actually working out really what's fundamentally going on with that practice. Actually, it might be, an issue in the family but if you know the family, you might actually know what's going on. And if you work locally, you might know someone else who tips you off what's going on. I think it was a whole, certainly in rural areas, your healthcare system is a network of hairdressers and various other people who feed back in going, I saw Mrs. So-and-so the other week. She's looking a bit frail. Has she been to see you? No, we better go out and see her and check what's going on. So, so the worry is they just think it's all about, I think your point about, this new 90% target, we've been here before.
I remember. I think 48-hour access and all of that.
I don't know if it's Steve Taylor, I know, who's been on you might be on a preceding one, and he posted a video of Tony Blair being questioned, I think, in some question time thing from 20 years ago about this, going, people can't book appointments because ultimately, if you've got to give 90% access on the date, well, you're going to have to deliver that. But that's going to be at the expense of someone else. So
I know we'll be so busy pulling them out of the water, and no one's going to go upstream to find out why they're falling in.
Exactly. Illness to prevention.
It's the opposite. It's funding the opposite.
So, Andy, you've spoken about the pitfalls of these formulas. Do you think a formula is possible, or do you think we should go to a system whereby actually just do a blanket way of funding all practices equally? Is that something sensible as well?
I'm not sure funding equally will be the right result, because there are practices that do have far bigger demands. I think, we can't be relying on data from the 1990s now to reflect how we fund practices. You just look at, mental health issues and young people. Back in the 1990s, where we didn't have mobile phones and all the worries of the world, younger people probably didn't go and see their GP an awful lot. So it was quite right they had a low weighting. But I suspect now your demand is quite significant from younger populations. So it's got to be updated to reflect that. It's got to be.
Do you think we can? Do you think it's possible?
I think it's really difficult to come to a formula that is going to fit everyone in the country. And it never worked. It never works now. It's not going to work better. But you have to go back to actually what we're trying to achieve here. Ultimately, you've got to try and achieve the encouragement of general practice to be able to thrive, and general practice to be able to provide the services it needs to do, because by doing that, it's going to save a whole load of costs at secondary care level. I think there are some bits within the NHS. The worry is that politicians just think the NHS is this great sinkhole into which we will solve the evils of society. If you went to a really deprived area, in the north of England, there's only so much the health service can do. If people are poorly underpaid, people don't have the right housing. People have all kinds of factors affecting their health. It's not your issue to solve, but I think the problem is it's being forced on you as being your issue to solve. So there has to be a whole, issue dealt with outside of that. Care homes and nursing care has to be dealt with, because otherwise, if we don't deal with that, the demand will just continue to grow and you will never solve anything. So back to your question, a formula that works totally across the country, I don't think will work. So what do you have to do then? Because ultimately you've got to get paid somehow. I think you have to break down the components of what you need to do. So there has to be a component that reflects the number of patients you've got on your list, because you wouldn't expect a 20,000 patient list to get paid the same as a 10,000 patient list. So there's got to be some component there that deals with the size. It's got to reflect the cost base, and the where ultimately we want the resource to go. So if the intention is to try and get more resource into deprived areas, we need to acknowledge their cost base needs to be higher. you know, bit staffing, premises, whatever. So it's got to deal with that. And I think it's also got to deal with what you do, you know, because at the moment, the contract is very much based on the number of patients on your list.
Yeah.
Like by this weighting. It's no real reflection of actually how many times you see them. So if we don't factor in something that reflects actually what practices are doing with their list, then again, we're not going to get it right. So if you're seeing your average, you know, your average person in your population 5 times a year, and the practices down the road is seeing them 3 times a year, well, you need to get more funding to deal with that. You have to ask why you're seeing them 5 times more, but actually there could be genuine reasons for that. Actually, you're seeing them because you're keeping them out of hospital. So, that formula needs to deal with all that, but you're never going to get it right. And this is the problem with the current emphasis on the formula is actually they just assume it's going to get right, and there's going to be populations out there this just doesn't work for. So we're going to have to say, right, and one of the things we did fight for when we were campaigning locally is actually some recognition of what's called atypical practices. And these are practices that have just weird populations or weird geography or weird, areas that they're dealing with, and actually just take them out of the system and go, right, we just got to look differently at them, saying what actually resource they need, we'll fund them that way. So you've got to have that safety net, otherwise it won't work.
Okay. It's going to be tough, isn't it?
I think part of the problem is people trying to measure what we do.
Yeah.
And I think they struggle to do that. So hence we have all of these.
And the new data, I know we were talking about the data is from the 1990s, but even the new data that we have right now, a lot of it's just all over the place. The GPAD data depends on so many things, that how the appointment book was set up, what system you're using.
Yeah.
It's
and the worry is, I think you're going to get some areas that are going to struggle more than others.
I mean, look at us. We've got 16,700 patients.
Yeah.
But we're paid for 13,500. So it's really heavily weighted, and my worry is that's going to get worse, and we won't be able to do some of the stuff that we do. So it's difficult. But let's end on a positive.
Okay, quick scramble.
So you mentioned some things that that should be looked at. If you were stuck in an elevator with Wes Streeting and you had 3 minutes, what would you say to him? And let's say 3 things that you'd want to get across to him. What would you say?
So the most important thing is, I think, preserving the general practice as a practice-based service is crucial to me. We've been distracted a bit by primary care networks, which is kind of forcing practices to work together. Now, that's not to say they're wrong, because I think in some bits, some things they do are really, really good, but actually it's distraction. And the worry is, as we move to the new neighborhood structures, we're going to get further distractions.
Yeah.
So I would say concentrate on the practice, okay, and get that right, because we get that right, everything else will be right. The second thing I'd probably say is make sure that we have fairness across the system. And the good example may be some things like enhanced services. And this is some work I work with an organisation called Medics Money, and we advise GPs. And one of the things we looked at is some funding for different services practice do across the country. And the variation just for a certain piece of service was vast. Actually, we need to go back to a system where actually that's priced nationally, and local areas either commission it from general practice or don't. But the third thing I would also say is do not raid GP funding to fund your neighbourhood model. Because it's the one part of the system, no part of the system's got enough money, but it's the one part of the system which actually is working financially. If we want to keep the NHS under financial control, it's the one part that's working. Don't destabilise that, because otherwise you've got a big problem. So, and it does need investment. So well, you say there's no money. I think there is money.
There's always money for waiting lists.
I think that, I mean, there's money because it's not spent well in some parts of the NHS, and that's where I do have sympathies with the government. You can't just keep chucking money at the NHS and expecting it to deliver. Actually, it's got to, there are bits in the system which need to run a lot better. I mean, technology is an interesting one, but your experience of what you've done within your practice in terms of moving to a new system. You've got to listen to people like you, because actually you've walked the walk and seen the benefits that it can bring. But there's other technology people waste money on, which just, it's often we go for the cheapest because it's the cheapest, not the best.
It's cheap this year. But in 2 years' time,
so names there. But I would say overall, if I was pressing the stop button on a lift, I wouldn't, because I hate lifts. So I'd let him get out. But really, 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 please do listen to people on the ground walking the walk. Don't just fall out with the BMA and have arguments with people like that. It was really, I was listening to different podcasts where Camilla Hawthorne was talking about her leaving the Royal College of GP post. And she talked about the 10-year plan when it was being drawn up. And she said, it was like a brick wall. The Royal College of General Practices approached the people writing that document to say, well, would you like some input, etc. And they got a brick wall. If you're not listening to people like that, you're just not going to get the right answer. So I do listen as well. And and please, if you are listening to this, don't just say the NHS is broken all the time, because there are so many people doing so much good work in it. It must be so disheartening for anyone working in the NHS to hear that message over and over again. Yes, it needs changing. Yes, it needs improving in lots of areas, but also it works really, really well in other areas.
Absolutely. Andy, on that note, thank you so much for being with us tonight. I hope that this gets the audience that it deserves. There's a lot of experience there, and that experience can be tapped into the Pow-thomas Associates. Is that right?
Pow-thomas Partnership.
Absolutely. And we're going to be using them. Lots of other practices are using them. So, give them a shot, because actually, there's never been a greater need for these kind of services, this kind of corporate memory as well. It all needs to be exploited. So give them a shout.
Yep. Thanks for inviting me on.
No, thank you. Thank you for your wise words.
Take care. See you soon.
Okay. Bye.